Hey guys, I'm Dr. Buffy, and I'm super excited to be here today with Dave Voepel, the CEO of Arizona Healthcare Association. Thank you for joining today. We're going to have a dynamic conversation just about long-term care and the industry and where we've been and kind of where we're headed. So welcome.
Sure. Thank you. Thanks for having me. This is awesome. Yeah, looking forward to it.
Great. So maybe we could start with just some of your background and really what brought you to AHCA and kind of where you see things going.
Yeah, absolutely. I've been here, I'm starting my fourth year, in my fourth year. I don't know how you want to call it. Been here since 2018. How's that? I came from Illinois, so spent 12 years as the executive director for the Illinois Healthcare Association, and came to Arizona after Kathleen Pagels decided to retire.
And so maybe you could just describe to us some of, your opinion about where long-term care, the landscape is right now. We're May of 2021 and have just been through a tremendous year of this global pandemic.
Sure.
And so where do you think we are as a long-term care industry and the landscape right now?
Yeah, I always like to put it in perspective. So Arizona is such a different model than the other 49 states. I mean, first off, we didn't have Medicaid until 1982. And then it flourished in long-term care because of the state legislature and things that they put through on our waiver with CMS, okay? So that is pretty recent compared to other states, which started back in the late 60s, early 70s for the most part. But Arizona is a different model in a way that we use home and community-based services as pretty much the epicenter or the delivery of services for our seniors. So in this state where we have a pretty big population of seniors, home and community-based service is the way to go 90% of the time. Other states that's flipped, where skilled nursing facilities will be used 80 to 90% of the time. So you can see that there's a cost difference, there's an influence difference because people are encouraged to stay home or to use their community services, and that's what Access, our Medicaid payer, pays for. So the difference between, for instance, my home state of Illinois, we had over 800 licensed skilled nursing facilities. Now that's, granted, the population in Illinois is 10.5, 11 million people. Here we have 6.5, 7 million people. We have 146 SNFs, skilled nursing facility. So big difference. So putting all of this in perspective on where we've been and where we're going, you kind of have to lead with the whole, okay, we rely on assisted living, we rely on group homes, we rely on assisted living centers and community services to get things done here in this state, which is good. It's great. It saves money. You still need the skilled nursing piece of it because acuity is something that has gone up in the HCBS system, and that has to be handled by the skilled nursing facilities. So then you throw managed care on top of all that. We've had managed care since day one, and now you throw a whole different dynamic into this thing. And so when we start looking at it from a pandemic standpoint, you have a lot of different players and a lot of different ways and different avenues to go. That's not to say that other states that they don't have it easier or something like that. But when you look at it from a government health standpoint, if you don't have clear and accurate leadership filtering down through your state departments, through your HCBS systems, through your SNFs, through your managed care companies, you can end up with a mess on your hands.
How do you think, our nursing homes in Arizona, what have been their greatest challenges during this pandemic?
So I think it's shifted. So at the very beginning with the lack of leadership, I think we saw this up at the Kirkland building up in Kirkland, Washington, to where they had 40% call-offs day one. We had that same thing. We had a staffing issue. Now we had a staffing crisis before this happened. Now the staffing crisis is exponential. It's huge and it's still going on and there's no relief in sight. It's still difficult to get folks to work in nursing homes. We refer to it as being mission-driven work. In other words, you have to want to work in it, and that's the best kind of person because they want to be there taking care of our elderly, which is huge. But then it shifted because we needed PPE, because now we have vaccines. So it's shifted out of that whole PPE need and all that other stuff into, okay, let's make sure people are vaccinated. Let's make sure that this is all, people are more safe this way. And so I think in that regard, it's been good. It's taken us a year to get to this. Mm-hmm. Of course, the vaccines didn't come out until the end of December for skilled nursing and assisted living. But overall, I think we've worked through the process as best as we can.
One thing I appreciate about ACA is all the education and training all throughout the year. And that has greatly diminished during this time because, of course, a lot of those trainings and education were in person. And so a lot of that was shifted to remote. And now we're starting to get back into some in person, which is really, really important. Do you think that's going to contribute to helping assist, say, new infection preventionists or get staffing more trained and that education?
Well, you and IPC have been an integral part of the whole education change around that we've had to do here at AHCA. I mean, you're part of the EPIC grant, you know, our whole infection control piece that through the feds and the state were allocated these dollars to help facilities. And you've gone into facilities and helped them one-on-one with infection control, which is huge. It's something they need. I mean, the press often questions us to say, well, with infection control, how come you're not doing that? And it's like, well, that's a good point. We had the flu season that comes in every October, so we should be up to speed on infection control. The difference is that we're not up, we know where the flu is. Somebody has a cough, the sniffles, they have a fever.
Do they mean where you as ACA are?
Yeah.
Oh, okay.
Yeah. And so why aren't we doing more on infection control before this hit? And it's like, well, first off, we were, but we knew where the enemy was. Mm-hmm. With COVID, we have no idea where the enemy was.
Right.
And if again they put it in perspective, they'll understand that the CDC wasn't to start with testing. I mean, fortunately, the White House came in within that first month, and they reversed that order that they put through, and then they got testing ramped up. So, and then they could start the whole testing process. But we didn't get tests here until June, July? We were going through our second phase by then.
Right. So we were operating, number one, this virus is asymptomatic.
Yep.
And then once people did have symptoms, it was blown through the whole building. So
easily.
I experienced that as well with nursing homes calling me, and it was just like a wildfire. And then, so fortunately the testing helped. Where do you see, like, moving forward, you know, I disagree actually with the press in that, because I was involved even with ACA before, and even there wasn't as much focus in infection control and long-term care, but it was starting to ramp up. You know, we had the new federal requirements, we had to have every nursing home to have an infection control program, antibiotic stewardship program, and then 2019 to have that infection preventionist. So we were getting there slowly.
Sure.
But nobody expected this unprecedented virus to then really, you know, throw us so far in the deep end where, like, ready or not, here we are, right?
Right.
So what is ACA doing as far as now, or what is kind of your vision to support long-term care in infection control, kind of moving forward? What do you see as that vision?
Well, first off, you always have to have the money behind you.
Of course.
You know, and Medicaid has always, they've been always the very end, you know, of getting any dollars. And we've been pushing hard. Last year, with the help of Access and our state legislature, they were able to put $54 million into our state program here for All-Tex, what we refer to as All-Tex Elderly and Physically Disabled, EPD program. So that was pretty big during COVID times. We're pushing for something similar this year, and the legislature, hopefully in its infinite wisdom, will help that end. So if they have more dollars to put towards things like infection control and testing and more awareness about what can be done, both on the infection control side, the disease side, we might not ever have a pandemic that is all around COVID, but we may have a different type of flu strain that becomes a pandemic.
Right.
So if we can learn from this and we put it into a into a playbook, for lack of a better term,
That's
and
good.
we're able to use that playbook for the future instead of being 6 months behind or a year behind in a pandemic. We're only 6 weeks behind because you have to have time to spool up.
Right.
You got to give people time to read the playbook, understand it, and operationalize it. So if that only takes 4 to 6 weeks instead of 6 months, we're saving lives at that point, which is really huge. And I think that's the whole idea behind this whole thing, is to how many lives can we save?
Yeah, and not just our vulnerable. I mean, we are this vulnerable population of residents, right? But then also our healthcare staff that are often not trained as well, and they're not paid really the value of what services they're offered.
Right.
And this may be a little controversial topic, but what about, and this, I guess I want to talk about like the state and federal survey process, because as I've gone around the country and been a part of many nursing homes, their work, I've seen that this has been their biggest headache.
Sure.
Even outside of COVID, in the fact that at their darkest hour, when they were in an outbreak, which is what triggers a survey process right now, outside of the normal annual, short-staffed because their staff have quit or they're out sick, shortage of supplies or testing, and basically you're in crisis emergency mode. It's like when the house is on fire, full on fire. Now your regulatory agency comes on site and says, we're going to see how well you're doing.
Right.
I mean,
and we're going to fine you for not having those fire extinguishers filled up in order to fight the fire.
Right.
Yeah.
And we're going to fine you
thanks.
if you're not operating at 100% perfection.
Yeah.
Truly.
Well, you saw it again referencing the Kirkland, Washington building. That was the first skilled nursing facility to get COVID in it. And CMS came in and fined them $650,000. Yeah. CMS was there day 5 along with CDC, and they were providing no help, but yet they turn around and they blame and fine the building. You can't even see the enemy. How are you supposed to fine them for doing it? They were doing the best they could.
Right.
And I'm just, that's sad, you know? And granted, we can't have a regulatory process that's just built on teamwork. In other words, the regulators come in and say, here, you should do it this way, and go ahead and do it. I mean, there has to be fines involved. There has to be a lot of repetition involved. You know, you have to have annual surveys. You have to do things in order to make sure you're keeping people safe, because some in this business will not get it. They have to be beaten over the head with the idea. Others will be not only get it, they'll get it ahead of time, and they'll be innovative with it. And the state and the feds have to keep up with that as well. So they have a big task to do in this whole thing as well. But I agree with you that there were some controversial pieces that it's like, man, it could have been dealt with a lot better, you know?
So it's almost, I feel, swung from this pendulum of like one extreme to the other extreme, where even nursing homes I've talked to now said that it used to be more collaborative, and it's just not as much. So what do you think maybe the future is for that, and where we need to go with the regulatory process?
So I think CMS, in their infinite wisdom, has seen through this pandemic at least some of the things that I'm hearing. For instance, in my 16 years of doing this, I've never once been contacted directly by the CMS region person, whatever their title is. Well, about 4 months ago, the Region 9 person called the office, said, so-and-so's on the office. And I'm like, well, okay, what's that all about, right? And he wanted to sit down and talk about how it's going in Arizona, and they see that we're doing some different things, see that this is going on, how have we fared through the pandemic, and just a, hey, trying to get to know you type thing. And then I invited him to a board meeting, which we had. It was an open discussion, it took an hour, and got some feedback going on. You don't see that of federal CMS. I mean, you see it of state, I mean, the state ADHS, they're involved there. You see them, you can talk to them, you could call them on the phone. Who do you call at CMS, right? I mean, holy cow. If the region doesn't handle it, does Baltimore handle it? I mean, who's doing what? And then when you get that kind of interaction, and now they're going to open it up to where we have region meetings. So the associations
Very good.
from the whole region will all get together with CMS. And we even offered to say, hey, you should bring the states in on this as well. And that way we can all hear what we're hearing. And then we bring in select group of members and we can have conversations about this stuff and figure out what the problem is, identify the problem, and then shoot for a goal. And if we can all have input on that, and then CMS comes down with their, directives and say, here's the next QSO memo that we need to do on this, something like that. I think that would be very progressive.
And it speaks to our culture of what you were saying earlier about how relational we are here in Arizona, and community-based. So it makes sense to bring in our other partners.
Let's collaborate.
We don't want to just work in silos. We don't want to duplicate efforts.
And contrary to what the state or the feds might think, we want to know what the rules are, and we want to know how to follow them.
Of course.
I mean, that was probably our mantra at the very beginning when this all started to happen. And we started to see all of this information flowing from everywhere. And the counties were pushing information out and all of this stuff. And we refused to do that from this end. So we physically sat down and we said, okay, with all of this information, we're not going to push anything out there until, number one, we have clarity on it. So we understand where all that's going. And then when we push it out, we want to make sure that we understand what questions might get asked and what can we get answered ahead of time. So that we can, instead of just pushing it out there and saying, okay, here it is, here's the QSO memo. What does that memo really say and what are they trying to get to? So I think that's one of the biggest things that we tried to do here is try to take all of the information and funnel it down in a way to where facilities could read it and operationalize it.
And you guys did a really good job. I mean, you have a newsletter that goes out monthly, right?
Weekly.
Weekly.
Yeah.
And I frequently go to your newsletter because I do know it's condensed.
Yeah.
And I don't have to look in 5 different places.
You can click on the links and get there, and we go with the one-click method. If you can't get there in one click, forget about it.
Yeah. And to your point, I mean, there's so much information out there, and then even more important, if our nursing homes or long-term care facilities aren't following the guidance precisely, then they're cited. And so that's why it's such a responsibility on us too to make sure that we understand the information that, as you said, you're disseminating it in a way that's understandable and implementable as well.
And you can always throw a little humor into it too. I mean, there's always a good place.
Dave.
Yes. So, I mean, you can use different things, and if people are really reading it, it's funny because I'll be talking to somebody. And it's like they'll throw out a new word and I'll be like, I'm using the word in the newsletter,
See if somebody catches it.
Yes, see if somebody catches it, It's like, or use just silly little sayings. Well, let's unpack that. And it's like, really, it's a newsletter. It's like, come on, just
And I think
stuff.
To your point, our long-term care facilities are so busy.
Yes.
And so the information has to be precise.
It does.
Clearly understand, be able to understand it.
It can't be wrong.
It cannot be wrong.
Because you will get called on that. It's like, what the heck are you doing? But we can only report what the government's giving us or what other stakeholders are giving us. So we can make it easier to understand. But if the governor does one thing and ADHS is doing another thing, we have to report those two things. That's confusing as all get out because which way are we supposed to go from a facility standpoint? Well, I can't tell you that. You have to follow both.
I know. I know.
So it's and we go back to the governor's office or back to ADHS and advocate for, okay, they're saying this and you're saying this and they're going like this. We can't have that. We need to bring it back around. And sometimes they don't know. They don't know what one agency is reporting as opposed to another agency. And it just happens. It's nothing malicious. It's just the way it goes sometimes.
Right. Well, I appreciate so much you having this conversation with me today. What's next for ACA and even your journey and where do we go from here?
Sure. It seems like during the whole pandemic, it felt like 10 years, just like for anybody else. It's like took 10 years off our lives. But now we have the responsibility to come in and lead past the pandemic. There's some people that are really good getting through emergencies, or you'd see it in soldiers all the time. They were really good at the wartime aspect of it and trying to figure out how to get to the enemy. But then when you pull them out of that war situation, they don't know how to function. The lack of leadership goes away. And so one of the things we're doing is we're transitioning. So we're transitioning our education programs, number one. Instead of being by virtual, we're going back to live and in person. So we have our big convention at the end of July. It'll be live and in person. And if people aren't comfortable in coming, okay, that's fine. I think people will be really comfortable in coming because we're going to still have some things to where, you might have to mask up and, different things like that. But all of our booths are sold out.
Wow.
So there's a sign,
Yeah.
So we have an outstanding lineup of speakers. I know you're going to be there speaking. We're going to have it's going to be a knockdown, drag out fun time. Further on past that, we have to continue not only fighting for the dollars for long-term care, we also have to fight for the regulations that make sense. So, that hasn't changed from the association standpoint. We have to listen to members not only from your side, but from the long-term care or the facility side to be able to figure out, okay, you might not want to do it that way, but that's the best way to do it. Now, how can we get it paid for? And sometimes you have to take people kicking and screaming, but that's all part of leadership too. And that's one of the reasons why we're here, is to lead our way through it. So.
Well, I'm so grateful that you are doing the work that you are and your advocacy and leading this great organization. And thank you for joining me
It's pretty
today.
easy when you got great members like you and all of our facility members. So thank you for having me.
Thank you.
Thanks.